entitled Patient Selection for LAA Closure Based on the Evidence. I think we all know that based on the recommendations of the in Europe and also in America, recent recommendations in 2017 and 2019, the recommendation is as follows. Percutaneous LAA closure may be considered in patients with AF at increased risk of stroke who have contraindication to long-term anticoagulation therapy. Similar recommendation both in Europe and also in the USA. So let me start with this interesting observations based on PROTECT AF, PREVAIL, and CAP and CAP2 study with the Watchman device, showing here that the hemorrhagic stroke and cardiovascular and unexplained death and also major bleeding, non-procedural related bleeding are indeed lower, significantly lower in the Watchman group as compared to the oral anticoagulant arm. And this difference is similar regardless of the patient subset, age, sex, gender, chest VAS score, Hess-Platter score, and so on. This is another publication in the year of 2016, comparing Watchman device and NOAC. And of course, this is not a head-to-head comparative study. NOAC is based on all the mega trials, RELY, ROCKET, and so on, showing here that in both analysis, Watchman as well as NOAC indeed reduced hemorrhagic stroke. Another interesting analysis is this one. This is a review of 6 randomized clinical studies and 27 observational studies where the patients were followed up for at least 1 year. So the network meta-analysis for randomized clinical trials showed that LAA was less effective than NOAC in stroke prevention, but it was associated with a lower rate of hemorrhagic effect. However, meta-proportion analysis of observational studies tells us that the LAA occlusion was associated with lower rate of both thromboembolic events and major bleeding rates, and with prolonged follow-up, these thromboembolic events indeed decreased. So the conclusion of this paper was as follows. Well, although superiority of NOAC was not demonstrated by randomized clinical trials, in terms of stroke prevention, LAA closure was consistently associated with lower rate of both thromboembolic and hemorrhagic events. Another interesting paper was this, based on cohort analysis of more than 6,000 patients, 60,000 patients who were on NOAC or OAC, and the proportion of days covered by more than 80% was less than 50%, both on NOAC and Warfarin. And the risk of stroke is, of course, higher, and this is compared versus 1 week. If the chest VAS score is more than 4, even in the first 3 months, the hazard ratio is already twofold. And after 6 months, approaching fourfold, and also in the chest VAS score, those with the chest VAS score of 2 to 3, after 6 months, 2.7. And this is again to show that Asians may behave differently. They have a higher risk of systemic stroke, cardiac embolizations as compared to the non-Asian populations, even though they are put on the NOAC. This is one of my patients showing here that even though the patient is on dabigatran, but he didn't take the drug regularly, and you'll appreciate here the presence of big pedunculated thrombus protruding into the left atrial cavity, and this is thrombus on the 3D TE dancing in front of the mitral valve. So let me share with you some of the newest data on registry data on LAA closure. This is a European Heart Rhythm Association survey In this survey, the main indications for LAA closure was a high chest score, but patient has contraindications of OAC or has a high blood score. And this is in the amulet registry, also in the year of 2016. The main indications for closure was previous major bleeding and high bleeding rates associated with bleeding, or the use of triple drug because patient underwent angioplasty or patient has a stroke or Warfarin or previous minor bleeding. So in Asia, this was most recent publications in Asian intervention by Gary and also Y.Y. Lam, data from Prince of Wales Hospital. And they reported this from their 160 over closure devices, and main indications were non-compliance to INR, history of bleeding, high risk of bleeding, and this in our hospital. We have the majority of our patients are those with the Watchman device, and most of the patients had high stroke as well as high bleeding rates, as shown by the high chest and high blood score, and also patient who has contraindications to oral anticoagulation therapy or systemic embolization, despite NOAC. And this is just to show the efficacy of LAA closure in selected high-risk patients, patients with chronic kidney disease, intracranial bleeding, and major gastroenterous bleeding. So the LAA closure offers a significant reduction of stroke and TIA as compared to the expected annual risk. For example, here, in all stages of patients with chronic kidney disease, this is the observed event rate here being much lower or significantly lower as compared to the expected event rate. And also here, intracranial bleeding and major gastroenterous bleeding was here with intracranial bleeding reduction as compared to the expected annual risk was ranged in between 60 to 75%. Here in gastroenterous bleeding, we put the patients on LAA closure. A reduction was ranged from 61 to 75%, regardless of presence or absence of prior bleeding. So this is just to show risk stratification model. Of course, according to the guidelines, we mainly use the test score or high blood score, but there are also other risk stratifications which can be applied. But this is not universal. For example, the type of atrial fibrillation, duration of atrial fib, serum biomarkers like inflammatory markers, BNP, TNT, the type of LAA, size, spec, presence of spec, morphology, and so on, and ECG. And this just to show correlations between LAA morphology and stroke here. Of course, the least stroke rate was observed in patients who had the chicken wing morphology, and the highest was in patients who had cauliflower morphology. So in conclusion, despite improvement of anticoagulation with NOAC over warfarin, the benefit of all OAC therapies do not come without risk of bleeding, and a significant number of patients are not on treatment, discontinue their treatment, at least 25% or over, and are not fully covered with adequate treatment in a significant length of time. Cutaneous LAA closure may be offered in selected patients as it offers significant recognitions of stroke and TIA, and LAA anatomy can be very different and could be linked to a different stroke and risk profile. Thank you so much.
Thank you very much, Dr. Santoso. So, because of the interest of time, we're going to have just one question. I think from the panelists, do you have any question to the Dr. Santoso? Yes, please.
A good speech. I have a question. The atrial fibrillation Chart-2 scores are very important for the embolism, but do you think if the burden, AF burden, atrial fibrillary burden is also important compared with Chart-2 score? For example, if a patient has a high Chart-2 score, but he has not frequent attack of AF, is the same risk of embolism compared with persistent AF.
I may not fully understand your question. You mean that the patient has AF, but the type of AF?
Higher C-score, but without AF. Do they also have increased risk of surgery? They have very high C-score, but no AF.
Yeah.
Very high C-score, but without AF. Do they have increased risk of surgery?
Yes, according to the guideline, yes. If the high chest score is high, then the patient has a